Okay. Yes, thank you again for great presentations. So now we're on to our second keynote of the morning, and it's a personal pleasure for me to be able to introduce Peter Orszag, who's going to do that for us. As with others, his extensive bio is in your packet, but he's currently vice chairman at CitiGroup and a columnist at Bloomberg View. He has his academic training in economics, PhD from the London School of Economics. And as you know, he served both as the director of the Office of Management and Budget and earlier led the Congressional Budget Office. He's an elected member of the Institute of Medicine. He's currently co-chairing another study on the long-run macroeconomic effects of the aging U.S. population. And he's going to talk to us today about how our health expenditures reduce education funding and ways we might think about structuring these investments better. So Peter, thanks so much for joining us.
Okay, thank you. I'm going to talk about actually three things. I'm going to talk about what was just mentioned, and then I'm going to talk a little bit about the impact of education on health. And I know that you've already been discussing that, but since I am co-leading that National Academies panel that is touching upon that, I thought I would just kind of lay out how I see the data. And then finally, I want to offer a little bit of room for hope in and explore the recent deceleration in health costs that would be a huge deal for the federal budget and for state and local budgets were it to continue, and then maybe have a word or two about what we could do to make it more likely that it will continue. All right, so first on the first topic, one way of coming to this point is to examine a variety of indicators about the state of public higher education that might be a little bit troubling. So one little comparison I like to do is to look at comparable public-private universities. So UT Austin-Rice, University of Illinois at Urbana-Champaign versus U Chicago, Stanford, Berkeley, et cetera, et cetera, et cetera. About 35 years ago, starting assistant professor salaries, especially in economics, the field that I know best, but overall, were roughly at parity at the public and private comparison schools. Today, the public university starting assistant professor salaries are roughly 15 to 20% lower at the public universities. And you might think that for some period of time, and this is why I'm focused on starting assistant professor salaries, that the same thing is happening to full professors, but for full professors, they may have some institutional loyalty, have built up a comfort zone at the institution and stay there. But for starting assistant professor salaries, you have to imagine that that's going to start to affect the quality of the professors that the public universities can attract. And don't forget, especially if you include the community colleges, which is obviously a different realm than this, somewhere between 2/3 and 3/4 of students attend public universities and not privates. Consistent with that, and the difficulty in attracting high-quality professors to universities, public universities, and I hate to use this because it's so superficial, but in the absence of anything else, I'll give you a couple indicators of quality problems, relatively speaking, at least at public universities relative to privates. The worst of which, but the easiest to calibrate, so that'll be the one that I'm using, is the U.S. News and World Report rankings. If you go back to the mid to late 1980s when the surveys started and complaints about them started at the same time, there were 8 public universities in the top 25, and UC Berkeley, I think if I remember, was ranked number 5. Okay, so there were a significant number, almost half in the top 20, and or top 25, I'm sorry, and UC Berkeley was ranked number 5. Today, if you look at the top 20, there's only one public university in the top 20, and Berkeley is that school, but instead of being ranked number 5, it's number 20. So there's been a very significant shift, at least on that metric, of the quality of public universities. And if you try to triangulate other measures of quality, you get similar types of concerns. Now, what does this have to do with the topic that we're discussing today? The answer is that research that Tom Kane at Harvard and I have done strongly suggests that a big driver of this decline in quality at public universities is the falling ratio of spending per student at public universities relative to private universities, and that in turn is driven in large part by shifts in state government appropriations. So, and that in turn is driven especially by Medicaid and other health expenditures. So, as I point out at the top here, if you go back 25 years, in general, state government support for higher education was 50% greater than state government support or spending on healthcare. Today, those ratios have flipped. And it's not just, and by the way, the next thing I think is kind of stunning. If the share of state government budgets devoted to higher education had remained constant rather than declining over the past, I think this was over the past 25 years, there would be an additional $30 billion a year flowing into public higher education, which is $2,000 per student. That is basically the entire gap that has opened up in spending per student between public and private universities. So this is a very big deal. And again, it's being driven by this, which is the rising share in state budgets that is devoted to healthcare spending. So here you have a very clear driver from healthcare spending into the education sphere that is affecting the quality of public higher education. The more formal econometrics that Tom and I did that use panel data at the state level, so you have state by year, suggest that what happens is that during these kind of ratchets, when during a recession, the share that's of state budgets that is devoted to healthcare increases significantly, in part because a lot of people come on to the Medicaid rolls during a downturn. That what states do is they then ratchet down the appropriation for public higher education during that time, and then it doesn't return to its pre-crisis level. So what will happen is the longer term trend is basically ratchet, and then you get a little bit pick up, ratchet, and the trend is effectuated basically through these step functions that are not completely undone. Now, the traditional answer to this has been, well, that's fine because, I'll come back to that, because states are able to raise tuition to offset the declining state appropriations for higher education. The problem with that is, again, go back several decades, state appropriations were roughly 4 times as important as tuition in public higher education. So if you cut back state appropriations by 20%, you'd have to raise tuition by 80% to offset it. That's not going to happen. So despite the fact that tuition has been rising significantly, and it has been rising both in real terms and as a share of public university budgets, it has not been sufficient to offset this previous trend of this decline in state appropriations for higher education because the previous share had been so much more dominant through the state appropriations perspective or channel. So what to do about that? There are several things that one can do. One possibility is to try to mitigate the impact in terms of upward pressure on state Medicaid expenditures during downturns in the hope that somehow if you could just kind of undo the ratchet, that this longer term trend wouldn't occur. That's spiritually aligned with an increased FMAP, the increased share of Medicaid expenditures that the federal government picks up as opposed to state governments pick up. One could have a automatic stabilizer that increased the FMAP automatically, as we did, by the way, during the as part of the stimulus bill, but to make it automatic rather than part of a discretionary legislative process. The problem with that is if the ratchet is just the mechanism for accomplishing these reductions and you still have that underlying trend of healthcare expenditures going up, it may be a more gradual effect, but presumably there would still be crowding out away from higher education. And by the way, to some degree, primary and secondary, although, as you all know, larger local component there, and also the impact on state budgets hasn't been quite as big. That's politically been protected a little bit more than public higher education. I think in part because of the misperception that you can just charge tuition to offset the higher education component. So ultimately, and I'm going to come to this at the very end, ultimately the only way to really get at this problem is to slow the growth rate in healthcare spending, because without that, you're going to be making sandcastles on the beach, and it's not really going to work. There's a whole lot of other data behind this suggesting, again, what I was just saying. If you look at, on average, at public university salaries, look on the left there relative to what's been happening at the privates. This differential trend has occurred over the past several decades. Also true, although probably we don't quite have the same sympathy for university presidents and so on and so forth. There is a significant gap in spending across the board that has opened up between public universities and private universities in terms of their trend, and that shows up in a whole variety of different categories. So that's basically point one, which is healthcare spending at the state government level has been crowding out appropriations for higher education and harming the quality of public higher education. Point two is, and I know you touched upon this morning, but one way of putting it is, it appears that the rate of return to higher education in particular, but probably to education overall, is understated in all of the literature that is out there, because that literature basically says you go to college for an extra year and here's the additional wage you get, and so the internal rate of return on college expenditures is 7% real, or whatever number people come up with, but it's usually magically 7% real. What that ignores is the growing evidence that not only do higher educated people live longer than less educated people, but that the gap between higher educated and less educated people is growing very rapidly. And to the extent, I'm going to now get into this in a little bit, but to the extent that that's causal and not just a spurious correlation, and I would say we don't have, we haven't done the randomized control trial, so we don't know for sure, but I believe that there is a causal mechanism, and we can talk through what that might be, from education on to longer life expectancy. Then the internal rate of return on education is higher than the traditional estimate suggests, because not only do you get the higher wage, but you're going to get it for a longer period of time. Regardless of whether you're in the workforce or not, you have the potential to earn more over a longer period of time relative to everyone else. Now, embedded in that is the assumption that the correlations I'm about to show you are causal in part, and also that the improvement in mortality that is attributable to higher education corresponds to an improvement in morbidity from the same channel. And that second piece is a little less clear, but I think it's not unreasonable to presume that if you have significant gains in mortality, at least part of that will show up in additional years that could potentially be worked should you choose to. All right, so let's just look at these data. I know you went over some of this stuff this morning, but I'll just try to reinforce it. It has long been known that there is a gradient in mortality by SES, but I think there has been too little attention to the fact that that gradient is steepening massively. I mean, I don't know if there are demographers in the room, but as an economist, my understanding of changes that are this big over this period of time is this is not like little shaking. This is a massive change over this time span in a demographic variable like life expectancy or mortality. So what this chart shows you is, you could look at the late 1980s. This is by education. There is a gap in mortality rates. This is in kind of midlife 40 to 64-year-olds between those who don't have a high school degree and those who have a college or more degree. But here's what's interesting. If you then roll forward to 2007, you can see that that gap has just widened dramatically. And in fact, at the bottom of the education distribution, and this is replicated in a variety of other indirect ways, life expectancy is flat to perhaps actually declining. And you see the mortality rates here, the flip side of that being flat to increasing. You can do this also by income instead of education, and you see basically exactly the same thing. So you see a much more rapid increase in life expectancy for the richest 10% of the population. This is using average index monthly earnings, which is the measure of lifetime earnings under the Social Security system. And you can see a much more dramatic gain in life expectancy, both for men and for women, at the top of the earnings distribution than at the bottom. And again, this is only over a 20-year period of time. And so to have the gap in life expectancy between the richest 10% and the poorest 10% increase by over 4 years over a 2-decade cohort differential, that is this is not a small change. This is massive change very rapidly. Similarly, you can see at the very bottom, if you took the average of the men and the women, you're flat to perhaps a little bit down. In Bosworth's data, this is driven entirely by the fact that the females at the bottom of the education income distribution are declining. Now, I should immediately say there is a whole bunch of concern about analyzing these data, because the person in the bottom 10% of the lifetime earnings distribution in the 1940s cohort might be of just kind of a different beast, a different kind of person than the person in the bottom 10% in the 1920s cohort. Similarly, a high school graduate, a high school dropout in 1987 may have systematically different characteristics than a high school dropout today, given the fact that the graduation rate has actually increased, and then it was flat and it started to increase again. And so you have selection effects that the share of the population who are in that dropout category have changed. To my knowledge, and I know that the NIH has a whole focus on this research, to my knowledge, no one has been able to perfectly control for that potential selection effect. It is a concern, but the fact that in so many different data sets, income, lifetime earnings, education, this basic phenomenon is occurring, at least attenuates the concern that it's all being driven by selection effects, because it would be a little odd that the selection effect on lifetime earnings was exactly the same kind of thing as with regard to education. So I could just keep beating this dead horse, different studies. The point is, there are lots of different studies suggesting a significant change in this gradient. Now, the interesting thing, before I get to, actually, let me just pause on this too. So we may not, I don't know the right way of putting it, we may not care so much about the health effects of education if we felt like everyone had the same access to that higher education. And I think we know that that's not true, but I just want to reinforce that point, because in addition to there being a growing gap or growing gradient in mortality, there is a growing gradient in college completion rates by income. So what this shows you is the fraction of students who not enroll in college, because we have a major problem in terms of not completing college for those who do enroll, but those who actually complete college. And you can see that although average educational attainment has increased between the early 1960s cohort and the late 1970s, early 1980s cohort, it's increased much more rapidly at the top of the family income distribution than at the bottom. And so that gradient has steepened. And again, we might not care that much from a normative perspective if we feel like if there's evidence suggesting that this is based on aptitude rather than differences in opportunity, which is why I think charts like this are perhaps the most damning indictment of equal opportunity in the United States that one could imagine. Because what this chart shows you is that students from the bottom quartile of family income in 8th grade who take a standardized test and score at the top quartile of test scores, so they're high aptitude kids, complete college at only about the same rate as students from top quartile family income who score in the bottom quartile of test scores in 8th grade. That simply should not happen. So from a normative perspective, I think a significant concern here is family income gives you a benefit in terms of education. That benefit to education accrues not only in terms of additional income, but then actually life expectancy. The net result of that means that we are actually starving low-income kids, not only of income, but of life expectancy extension opportunities because of the growing gradient in educational college completion. And there's a whole bunch of evidence suggesting that that's not just aptitude. All right, that's kind of depressing, so now let me turn to something that's not. A lot of what I said, especially in the first component, has to do with trends over time in healthcare spending and how that will affect state and local budgets and therefore higher education. Obviously, there's also a very significant component of the federal budget. In fact, I'd say the primary driver of our long-term fiscal imbalance at the federal level is our growth in Medicare, Medicaid, and other health expenditures. It's often forgotten that between now and 2050, Social Security is projected to rise from 5% of GDP to 6%. And under the official projections, which I'm going to come back to in a second, Medicare, Medicaid, other health expenditures are projected to rise from 5% to somewhere between 10 and 20% of GDP, depending on which set of projections you use. That's where the long-term fiscal gap is. So now for a piece of good news before lunch. Healthcare spending has slowed down dramatically over the past 5 to 6 to 7 years. This chart shows you spending, real spending per beneficiary in different parts of the health system, private insurance, Medicare, Medicaid. Notice they've all decelerated. There is a raging debate going on about how much of the total slowdown is attributable to the economy and how much is structural. And the reason that matters is to the extent that it's cyclical, as the economy eventually comes back, let's hope it continues to, that would get undone. Here's what I think is very interesting about that. First, all of the macroeconometric studies that try to say it's 37% the economy and 67% this, et cetera, it's all misspecified, macro level, 30-year, basically you have 30 data points, and if you add 2 data points, the share goes from 37% to 150%, or if you go from 30 data points down to 25, it falls to minus 15. They're misspecified macro regressions and basically should not be the basis for any serious analysis. Here's what I do think is more illuminating than that, though. Medicare, the evidence suggests, is not driven by cyclical forces. And this is intuitive. Most Medicare beneficiaries have some kind of wraparound insurance, whether Medigap or an employer-provided wraparound coverage. So their net out-of-pocket expenditures are pretty low. For most Medicare beneficiaries, the majority of their income comes from Social Security. So it's protected against fluctuations. Consistent with that, if you look across states, in the commercial space, the states that were hit hardest by the recession were the ones where this slowdown was the most significant. But if you look in Medicare alone, the states that had the biggest increases in unemployment or the biggest declines in housing prices had zero correlation with the states that had the most significant declines in Medicare spending growth rates. More formal econometrics also underscores that point. So I like to focus on that middle graph because you don't have to worry about the economy there. So if you focus on what's going on in Medicare and whether that's going to continue, it's a pure measure of non-cyclical changes because the business cycle is not really affecting Medicare very much. That's important in evaluating. There's been basically over the past month a lot of press hoopla that the slowdown that has occurred in total healthcare spending is now done because of the 2 bars on the right there, that in the fourth quarter of 2013 and the first quarter of 2013 and the first quarter of 2014, healthcare spending overall in the GDP accounts picked back up, as you can see in that graph. The problem with that is there was something else going on during that time that you may be aware of, which was a lot of people were becoming insured. And this doesn't say anything about whether costs for the already insured have accelerated or not. It simply says if you add a bunch of people to the rolls of insurance, costs are going to go up. And then the question becomes, once that happens, what's the underlying trend? So I'm not overwhelmingly taken by the press analysis of this phenomenon. I mean, at some point the deceleration may end, but I don't think this tells us very much at all. And that's why I find it particularly interesting that the great deceleration in Medicare has continued well into this year. In fact, the most recent data that we have, CBO will be updating this actually probably tomorrow, or if not early next week, for May. But for the first 7 months of this fiscal year, Medicare spending was up a whopping $2 billion in nominal terms relative to the first 7 months of last fiscal year. That's 0.7%. That's nothing, because when you then take out beneficiary growth and then you take out inflation on a real per beneficiary basis, this is highly negative. And that's through April of this year, continuing that underlying trend. Now, if you want to see how, I'm going to skip ahead for a second. You want to see how big an effect this would have on our long-term fiscal future? The top blue line is the basis for pretty much every editorial in the Washington Post about our long-term fiscal gap being totally unsustainable, which under the official projections it is. But just to show you, A, how big the slowdown has been, and B, how big an effect healthcare spending has, how sensitive our long-term fiscal gap is to healthcare spending growth rates. Blue line's the official projection. Orange line, which basically, I'm going to simplify, but basically is sort of take the last 20 years, cost per beneficiary, project that forward, but realize that's not going to be sustainable, so walk it down arbitrarily. That's basically our official projection methodology. If instead of doing that, you took the last 5 years as the basis for projections, you'd wind up on the bottom orange line, which is to say the entire rise in Medicare as a share of GDP disappears despite the baby boomers. And that in turn means that basically the entire long-term fiscal gap facing the United States disappears, which is to say, if we could simply perpetuate the growth rate in Medicare spending per beneficiary that we have actually experienced over the last 5 years, when again, the business cycle didn't seem to have anything to do with that, everything that you think you know about the nation's long-term fiscal gap would be wrong. And consistent with that would be, yeah, that's good news. I told you I was going to end on good news. Now, I'm going to do two more things quickly. First, it's not just me who's noticing this. The Congressional Budget Office, which I can assure you, having run it, is a fabulous institution, but not an overly dynamic place that likes to incorporate new information very rapidly into its estimates, has already taken basically a 10-year deficit number and walked it down by $1.2 trillion. $1.2 trillion reduction in the 10-year deficit number because of the ongoing deceleration in Medicare and Medicaid spending. So that is far larger than all the cuts and deals and whatever that you hear about people discussing and then not happening. Again, a really big deal if we could continue it. And that then raises the question of, well, can we continue it? Because this would have massive consequences for all sorts of things, including our fiscal gap, including state and local budget gaps, and therefore education, and so on and so forth. And there is one caution point, which is we've kind of sort of seen this once before. If you look in the late 1990s, there was also a significant deceleration in Medicare spending. But the good news is that was a dramatically different beast than what's happening today. That deceleration basically happened because in the mid to late 1990s, policymakers, through legislation, reduced the payment rates to providers. And so that deceleration was all price, basically. Today, however, this deceleration, if you look at that minus 0.2 percentage points, so there's been a 320 basis point slowdown, of which less than 10%, 20 basis points, is due to changes in payment rates. Most of this is due to utilization. So it's not really changing mix of patients, and it's not really paying providers less per procedure. It's that we are doing fewer things. The utilization growth rate are not doing fewer things. We are, the rate of increase in how many things we do is slowing down relative to history. That is a much more promising vignette or moment than if it were all just done by price. Because when you just ratchet down provider payments, you can slow nominal spending for some period of time, but it's ultimately not sustainable. The only sustainable way of slowing the growth rate in healthcare over time is by slowing utilization growth rates. And that appears to be what's happening. So my frustration is we are at this moment when past 5-6 years have been pretty good, but it requires a lot more policy attention to reinforce this trend, and the benefits would be massive, including for things that you all and we all care about, education, with a kind of wraparound benefit then to health itself. I thank you very much, and I think I have time for some questions.